Welcome, everybody, to today's session. I'm Mandana Khalili, Professor of Medicine and Director of UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodian of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We're proud to continue the tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. We are today honored to have Dr. Neeta Thakur, one of my colleagues at UCSF. She will be speaking to us on identifying strategies to reduce respiratory health effects from climate-sensitive events. Dr. Thakur is an associate professor at the University of California, San Francisco, where she's the co-director of the Partnership for Research in Implementation Science for Equity Center, and the interim co-chair of the research for the UC Center for Climate, Health, and Equity. The concept of opportunity has informed Dr. Thakur's federally funded research program. Opportunity determines where people live, how individuals are treated, and their overall socioeconomic wealth, each of which is an important risk factor for developing lung disease and other diseases, as well as contributing to morbidity. Over the past decade, Dr. Thakur has developed a novel research agenda that is directed towards identifying community-specific drivers that place individuals at high risk for poor outcomes, and co-developing place-based and targeted interventions aimed at social and environmental factors to improve respiratory outcomes in historically and persistently marginalized populations. During her presentation, you're more than welcome to put questions through the chat function, and we'll be happy to address those along the way. But we also reserve time at the end of the presentation for a questions and answers session. Dr. Thakur, welcome, and we look forward to your presentation.
Thank you so much for having me here today. Let me go ahead and share my screen. I am excited to talk a bit about some of the work that we've been deeply doing with our community partners for these last few years, and also just sort of talk about how we got into the climate change space as a way of thinking about addressing upstream structural factors that we know are contributory to health. And so I just wanted to take a step back and kind of talk about the communities that we have been working with around the San Francisco Bay Area. Many of them live in neighborhoods that have faced historical divestment. One example is through the practice of redlining that has led to a loss of wealth and also purposeful placement of environmental hazards, increasing pollution and other toxicities around and in the communities. Also, because of the divestment, we also see a concentration of poor housing quality in those communities, and that has led to negative health consequences. And as a pulmonary provider, one of the diseases that I'm most interested in is thinking about asthma. So both the incidence of asthma, but also increased asthma morbidity. And so when thinking about why think about climate events and climate change, as all of us have experienced in these last 4 or 5 years, we've been seeing increasing extreme heat events and wildfire smoke events. And when you look and see which communities are having the worst health outcomes during those communities, are there also the same communities that are experiencing higher morbidity from other chronic diseases? Part of that, because of the structural and social factors, many of those communities are overexposed during climate events. Also, because of the chronic healthcare problems that may exist in the communities, there's an increased sensitivity to both extreme heat and wildfire events, as well as droughts and flooding. And because of the lack of resources within the communities, the ability to adapt has also been impaired. And so addressing sort of the preparedness and also the recovery from climate-sensitive events can be a way of also addressing longstanding chronic disease in these communities. I also want to just highlight we're in a pretty critical juncture to do investment with climate resilience. The federal government and the state government have put a lot of money into climate infrastructure. And we, as for those of us that are in the health equity space and may bring like an environmental justice lens to our work, this is also an important time to work with communities to ensure priorities are identified and that funding, this large investment of funding, billions of dollars, is making its way to those that need it the most. And so I broke down this talk first to talk about community partnerships and why they're important for addressing climate and environmental injustices. I wanted to talk about the role for implementation science, and then provide two case examples of how both community partnerships and implementation science are helpful when thinking about prioritizing and co-designing place-based interventions. And so I like to share this NIH continuum of community engagement. And when we're talking about this type of work, I'm considering skewing towards the left of the continuum and really thinking about how we can better involve our community partners, really collaborate, and then at times actually going with a shared leadership plan where the community are really shaping and directing the intervention design and also the study. And so my work over the last several years has really been towards this left side of this community engagement continuum. And so part of when you're thinking about environmental justice and climate justice, it's really important to recognize and acknowledge the role of structural racism and how that has been pervasive and really has led to purposeful divestment from these communities. And part of thinking about the community partnership structure is really trying to redefine the power dynamics and really heed to the community to share what direction the work should go in a way to build community resilience. And so how do community perspectives improve science and then also improve ultimately health outcomes? So I view my partners as the experts. They're the contextual experts who hold both the historic and current knowledge of the community. They have deep experiential knowledge of what has worked and what has not worked in the community. And as we collect data as scientists, it's really, really important to ensure that you ground truth these findings with the experts. It's also that our community partners hold the trust of the community. And so when thinking about moving forward, particularly with interventions, that trust becomes a really important piece of being able to move forward with implementation. Our community partners are helpful in helping prioritize the types of interventions or the targets for intervention, having a nuanced understanding of community needs, contextual knowledge of barriers and levers that can be accessed. They're also a good barometer of determining what's acceptable and feasible within that community. And when it's time for implementation, they have a refined understanding of intervention targets, including co-developing both the interventions that you're thinking of bringing in or are considering, but also the implementation strategies that may increase uptake of such intervention. And then lastly, I always wonder if I should put this box at the start or at the end, is really the focus on sustainability. When thinking about work that's done in partnership, it's super important to have this conversation at the very beginning and kind of think about this as part of your implementation conversation, to help both improve acceptability and uptake, but also ensure that this doesn't become yet another grant-funded project that sunsets once funding is done. And kind of going into this model, and these relationships of really thinking that the relationship is the important part and the research is occurring secondary to that relationship. And now talking about going from thinking about the important parts of the partnerships, but also thinking about how does implementation science fit in. For many of the sort of structural and social determinants that we're considering, there are a lot of evidence-based solutions, and we'll talk through a couple of them as I talk through our case examples today. And selecting those solutions really is driven by local context, and that should be prioritized by the community partners. And then the implementation science frameworks really help with identifying both the barriers and levers and providing a very systematic way of thinking about what intervention may work, but also where implementation strategies and what level implementation strategies are needed. The other thing I just like to comment on is that when thinking about implementing projects and using implementation science, partnerships are inherent to that process. We really rely on local contextual experts to understand how an intervention may or may not work, and really drive the selection of implementation strategies. And so this ties back to why community partnerships are so important when thinking about addressing these health inequities. And so I'm going to dive into our first example. This is Richmond, California. This is a picture I took now several years ago from one of the hillsides, and in one picture captures a lot of the environmental hazards that the Richmond community experiences. One in the background, you see the Chevron refinery. On the left, you see one of the chemical plants, and then down in the forefront, you see one of the multi-lane highways that has large diesel trucks right here in the front, coming through the community. So this Richmond faces several different environmental hazards, and this one just captures a few of them. And when thinking about asthma, we want to think about where does asthma spatially concentrate, trying to understand and identify what might be underlying social and structural factors that contribute to high health burden. So here on the left is a map of the emergency room visits due to asthma across the San Francisco Bay Area. And Richmond, California is right here. This community that is dark red, showing that there are greater than 140 asthma ED visits per 10,000 in this community. And just for reference, the California average for ED visits is around 50, so it's more than twice the amount. What we also see here is the socioeconomic status breakdown for the Bay Area. And what you can see is that in Richmond, California, that there is a higher proportion of individuals that are considered low income living in the community. And it's also the same area that we see higher ED visits for asthma. And you can see that across the Bay Area. It's not just Richmond that has a high burden of asthma, and you see it tracks with socioeconomic status and these other communities, including Bayview, Hunters Point, and also the Oakland community. Here is demonstrates where diesel exhaust pollution is most prevalent. And similarly, the higher exposure to diesel exhaust pollution, you're also seeing higher rates of ED visits. And then when you look at where people live, which demographics live where, which racial and ethnic demographics live where, you can also see that the communities that are experiencing higher levels of poverty, increased exposure to diesel exhaust pollution, are also tend to be individuals of color. And so you're seeing a higher proportion of Black individuals and also Latino individuals living in the Richmond community. And this is, we can go into why that is, but I really wanted to be focused forward. But this is, part of it is from decades of divestment and segregatory policies that has led communities of color to concentrate in certain areas of the Bay Area. And so we know that there's a higher risk of asthma in certain communities in the Bay Area. And this picture here on the left is considering these socioeconomic factors and also underlying pollution burdens. And we've mapped out what is the underlying risk for asthma exacerbations in the community. And what you see here is the Richmond community. And they have an underlying higher risk for asthma, which is not surprising. All of the pictures I just showed you before show that there is a concentration of risk factors in that community. But what we've found is that when there are wildfire smoke days, we also see that there's an increased risk of asthma ED visits because of wildfire smoke, also in those same communities. So there is a lot of discussion that wildfire smoke impacts individuals equally because we're all being exposed to high levels. But what we were able to find using data from the UCSF Benioff Children's Hospital Oakland data set is that actually these ED visits are happening more in communities that have these underlying risk factors for asthma, showing that there is a sensitivity factor that is playing a role. And these findings are actually going to be presented next week at the International Society of Environmental Epidemiology. We also found that communities that are experiencing extreme heat days, particularly those that are of longer duration, are at increased risk of also having ED visits due to asthma. So this is a reason to think about why should we think about climate resilience when thinking about addressing chronic diseases, is because this underlying sensitivity is really increasing risk for additional negative health effects during these climate sensitive events. And so I've kind of given you the background on asthma in the Richmond community. I wanted to tell you a little bit about Richmond as well, kind of thinking about what is the context and who is the community that we're working with. And so Richmond, California was founded in the early 1900s. In the 1930s, there was a large influx of the African-American population, really in response to World War II and the need for shipbuilding. Because of segregatory policies, that community had to live in this temporary housing that was built in the 1930s, wasn't expected to stay around and be replaced with permanent housing. But that temporary housing is actually still in use today as permanent housing structures. And then in 1909, the refinery became built, but they were bought out by Chevron in the 1960s. And then this caused an influx of a new population to the community because of employment. It also is a source for pollution in the community. And so now you're dealing with this balance of economic opportunity and environmental hazards happening in tandem. And then more recently in the 1990s to even now to the 2000s, we do see a demographic shift in the population where Richmond was historically a predominantly Black community has sort of shifted to a predominantly Latinx community as we've seen immigration from both Mexico and Central America in the community. In general, most of the employment opportunities are considered to be more of labor positions, and much of the community is of low and moderate income. And I know I mentioned the refinery, and part of the reason of talking about refinery is because we do know that in counties that have a higher density of refineries, also have more asthma ED related visits. And that's what you see here, is that for individuals living near the refinery, you see higher risk of asthma ED visits. In 2017, we started a partnership with Lifelong Medical Care, specifically the Williams Jenkins Health Center, which is located in Richmond, right in the center of the Iron Triangle, which is considered to be one of the more overexposed communities that has one of the highest rates of asthma. We worked with our community partners to better understand the intersection of social and environmental adversity on health, and started a case control study with them. And what we did is that we put up low-cost sensors all around the community to better understand exposure risk. We asked our participants about different social stressors that they might be experiencing, with the idea of trying to understand what interaction of exposures really contributes to negative asthma outcomes. And so part of the goal was to think about what are pollution sources in the community, and then what are place-based social stressors, with the hope of being able to identify targets for actionable change, and then understanding those health impacts. We were collecting a ton of data, but we did not have a lot of input from the larger community on perceptions of these hazards that might be identified, what are resilience factors in the community, and where were priorities in the community. So in 2019, we launched a Youth Participatory Action Research program, where we worked with anywhere from 6 to 8 high school students from Richmond, California, to inform and direct our research priorities. The curriculum we used is from the YPAR Hub at Berkeley. I encourage you to check it out. It's a treasure trove of curriculum and ideas on how to conduct and lead different types of sessions with community members, and particularly with young people. And part of the work was also to enable or empower our youth partners to feel like change makers in the community as well. So over the last several years, we've undergone a series of projects with our youth researchers, trying to understand the context a bit more in the built environment, trying to understand community perceptions around interventions, and then also understand the priorities in the community as well. So for understanding the context, one of the questions from our youth partners was trying to really understand what aspects of the built environment contributed to poor health. And we used a neighborhood audit tool called a systemic social observations tool, and then went on walk tours with our youth researchers in capturing aspects of the neighborhood. And so these are the types of pictures our youth researchers took. And, here's what could be perceived as graffiti. But when looking at the message, it says grow together. And so this was considered and marked as an asset, and marked as a cultural art by our youth researchers. Here's an example of a poorly maintained sidewalk that our youth researchers are traversing through, and commented as a disorder and poorly maintained area. These all of the collections over 16 different census tracts where were put into a principal component analysis to see if we could identify what combination of factors might be associated with asthma ED visits using the census tract data. And what we found was the first domain was one that concentrated features of safety, or what we also call streetscape together, positive streetscape. And so well-maintained, having sidewalks present, having neighborhood watch signs present, having parks and trees present. And those features, or I should say the lack of those features, were associated with higher ED visits at the census tract level. So now we, from our youth researchers, had a better idea of like how social and structural determinants of health are operating locally and contributing health. And now these are things that are that potentially could be intervenable on, while something like as abstract as poverty is a lot harder to intervene on. And so one of the questions for the next cohort was to really understand what contributes to feelings of being safe in the neighborhood, or, this positive streetscape. And so our youth researchers use photo voice, which is a qualitative method where community members take pictures to highlight issues and share perspectives within their community through storytelling. And each researchers took 25 pictures. We actually had them use the old actual buy from Walgreens type cameras because we wanted them to be very intentional about the pictures that they took. And then they wrote down where the picture was, why they took it, and what they learned from it using what's called a show document. And then from those pictures, they picked 10 of them. And then they interviewed each other using a semi-structured interview guide that they developed. And those interviews were then coded by each one of them. And then you can see here on the left them gathering all of the codes, the themes and identifying the themes that came out from this work. And so these are identified by our youth researchers, and the themes that they saw that contribute to feelings of not feeling safe or a negative streetscape environment were things like the presence of trash, and then having poorly maintained areas, whether they're parks or sidewalks. One of the sidewalk ones I remember clearly that goes with this one is that my grandmother can't walk along the sidewalk because she uses a walker, and if she walks, her walker will get caught on these uneven sidewalks. They also identified sort of social and structural inequities that are occurring in Richmond, and also the role of addiction. There's several pictures of broken bottles and also of injection materials that were in the community. They also used the opportunity to identify solutions and places that had a positive streetscape. And so they came out with these 4 recommendations as potential areas for thinking of intervention development. And one was thinking about improving neighborhood quality. How can we bring community and be more involved in different activities? Increasing awareness of community resources. This number 3 comes up actually every single year from our YPAR partners, and then thinking about advocacy for the unhoused. And then from this, in 2003, the youth researchers developed a community survey and actually listed out all of the youth identified strategies that they thought would be interesting and important to see in their community, and get input from the community members on those priorities. And they wanted to survey a representative sample in Richmond. They used social media outreach, but to ensure that they weren't just getting their peers, they also went out to different spots in Richmond. So looking at where food distribution happens, to churches, to different community events that were happening. One of the challenges is that they had to accrue their sample size in 2 weeks, which is a very short period of time, but they were more than successful. And I wish I had this much success when I was doing my other research, but they were able to get over 300 survey respondents with pretty good completion rate, with 90% of the population completing the surveys. And pretty representative, with about 40% monolingual Spanish speakers responding to the survey as well. And so when we look at the breakdown about where and what interventions were ranked, the 2 highest ones were around more trees, and then also around more green space and improved park quality. And so in thinking about that, our youth partners came out with these recommendations for interventions for considering for co-developing a place-based solution on. And one was around more trash one's around more trees and more high quality green space. Of these three, our youth researchers were most interested in planting more trees in the community because they felt like it also addressed the more high quality green space at the same time. And so so when thinking about it, it's like, okay, well, is greening a good solution? There are two randomized controlled trials that does show greening decreasing gun violence in neighborhoods, and then a second study demonstrating that it improves mental well-being. We also know from more observational or epi studies that having more green space is associated with decreased asthma ED visits. And so when thinking about greening for Richmond, it's like, well, what is the thing you're trying to address? And the part of it is trying to address the exposure to pollution in the neighborhood as a way to decrease ED visits. And so what we did is take their solutions, and then we, as sort of the technical experts, ran different simulations to understand how greening in Richmond, California would decrease ED visits. And so this is also going to be part of this work was presented at the American Thoracic Society recently. Additional work will be presented at this upcoming ISEE meeting. And what we found here, first we had to calculate, well, how much does fine particulate matter contribute to asthma ED visits? And so what we found was about 23% of all emergency visits due to asthma are attributed to fine particulate matter. So a pretty good amount, right? Like that's kind of a high amount to see as a being attributed to it. And then the second part was to understand, well, if you added trees in the neighborhood, what would happen? And then also asking, well, how should we add trees to the neighborhood? So we ran a few different models. I'm just going to show you two examples of the models that we ran. The first one was saying like, well, everyone gets trees. So even if you have trees in your neighborhood, you're going to get more trees. And in fact, you're going to get a 10% increase in the number of trees that you get. And I will say this is a population-wide, considered like equal distribution method. And so what we found with this population-wide distribution of increasing trees in the neighborhood is that you would reduce the overall emergency room visits by about 2%. Which is good. It's not great, but it's somewhat of a small impact. However, if you said, I'm only going to plant trees in neighborhoods that are most susceptible, so have the highest risk of having an asthma ED visits, and use sort of this justice distribution model, then, and really meaning not everyone gets tree, but really concentrating the efforts in the neighborhoods that are most exposed and most at risk, you actually see that the reduction in ED visits goes all the way up to 7.5%. And so this was something that was a lot of interest to our youth partners and also our local municipality partners and also our CBO partners. And in fact, there is actually a lot of tree planting going on in Richmond, which I was happy to learn that I didn't have to go raise a bunch of money and think about how to do a tree planting intervention. And so rather is saying like, well, where is tree planting occurring and how is that working in the community? And so this is where implementation science has been really, really helpful in trying to understand what are additional barriers to this promising intervention. And so we are using the consolidated framework for implementation science for this work. We've added in an environmental justice lens to this, to CFR, using work from Dr. Mirella Frasch, where in addition to the outer setting, we've purposely added the social political setting, and then we've also added in some other domains of environmental justice in here. And so using this framework, this summer, our YPAR interns actually did a qualitative study and did semi-structured interviews with different CBOs and government partners in the community that are all engaged in tree planting. And so the intervention that we're looking at is here, it's tree planting. And then this is a little bit about the implementation process. And so who identifies where trees should be planted? It's both the CBOs and government partners. Who like designs the intervention, like what trees, where to plant, and then sort of like using pilots or small grant funding to decide more, with the ultimate goal of integrating into the general plan. So I'm just going to focus on one domain, or one theme that we identified, and just kind of talk through how that's been plays out across these different levels. So the first, thinking about the individual level and talking with our different CBO and government stakeholders, is that a lot of times the tree planting depends on volunteers, because of the way the funding is structured for this intervention, which gets to sort of the inner setting. Funding streams are inconsistent, so we don't have consistent funding for providing organizations that do tree planting, with sustainable funding streams. And then often that funding is tied to trees only. So it's often a capitated system, like we'll give you this much money for this tree, but it doesn't fund for the staff time or the maintenance of those trees. It just funds the trees themselves. And so that's been another barrier that we've been able to identify at the inner setting level. At the outer setting level, there's these interesting requirements for matched funding. So for example, if a more affluent neighborhood or area gets together and says, we want to put forth this much money for greening in our space, then the city has to match that funding because of a California policy. And so this actually ends up worsening disparities, right? Because more affluent neighborhoods have the socioeconomic wealth to plant trees in their neighborhood, and the city by default is forced to match that funding, doubling the investment in that community. So that was something new I learned during this process and found really interesting. And then lastly, because of the investment, or the influx of climate funding at both state and federal level, there's actually a lot more money that's coming in for nature-based solutions. And this is maybe more of a positive opportunity that's happened. And Richmond, California just received a transformative climate community grant, which is allowing them to plant more trees, but the barriers below around inconsistent funding streams and dependent on volunteers still exist. So this really just all falls under this major barrier of funding restrictions, and how most of the funding is for the actual tree planting and not for staffing and for maintenance. So this is something we're going to move forward with our different partners to kind of think about, like, how can tree plant grant funding be more holistic and applied more holistically, both by the state and federal funding sources. And so this work was made possible by all these amazing individuals through our YPAR program over the years, also from our members in the CLEAR Lab and partners at Lifelong and at both here at UCSF, Berkeley, and at San Diego. I am going to head into another example around wildfire smoke and single room occupancies. This one will be a lot shorter because this is a newer collaboration, but I thought it was a nice example of thinking about wildfire smoke as the thing that you're wanting to improve, and how it's taken me more into the indoor air quality space as a result of the partnerships. So we know that wildfire smoke days are happening in more frequency over the last decade because of human-generated climate change. We also know that the annual PM on the Western Hemisphere has increased dramatically because of wildfire smoke. And we also know that there's a lot of health outcomes, which I shared earlier, associated with wildfire smoke, particularly in the days of wildfire smoke events, but also the days after wildfire smoke. And so we know there are different exposure patterns to wildfire smoke. So during wildfire smoke, the #1 public health guidance is to stay indoors. But what happens if you live in an old building? This study shows that for older buildings, we see that the amount of smoke that comes in, so a higher infiltration ratio, is higher compared to buildings that were built more recently. So older housing stocks, particularly those that lack central ventilation, that that guidance to stay indoors is a little bit false hope because they're still going to have high exposure to wildfire smoke. And so I'm going to just skip the extreme heat piece, but there's also this coinciding with extreme heat days where we keep windows open. So it's a conflicting recommendation. So one of the building types that we work with is single room occupancies, which are high density multi-unit housings. This housing type came in the early 1900s as a way to increase housing access. So again, these are temporary housing buildings that have now converted into permanent housing solutions. And then San Francisco in particular has doubled down on SROs as a low-cost housing option, but this is actually something that exists across the country, not just in San Francisco. And this is a population that obviously is of lower income, but also, a lot of them have chronic health conditions, with 60% reporting chronic health conditions. And so when thinking about strategies of decreasing exposure during wildfire events, one of the strategies is thinking about, well, maybe we should better seal these old leaky buildings. This is tough because at the same time, then if you're going to go seal those buildings, then you have to also ventilate these buildings, because the way it wasn't until the year 2000 that we're required to have mechanical ventilation systems in all buildings, larger buildings that are built. And so this is a strategy that may be effective, but may have some unintended consequences. The other potential strategy is air purifiers. And we know that they're effective to reduce indoor fine particulate matter. In fact, they can reduce the indoor particulate matter by 30 to 80%, depending on amount of use time. And this shows you the peaks in wildfire smoke here in the dark line, and then how, if you use a HEPA filter, that your levels stay low while the outdoor PM spike. So this is also a potentially effective intervention, but obviously just at the individual level and doesn't address necessarily the larger structural issues. And so this is a problem with potentially many solutions. And so and thinking about it, trying to understand which solution to move forward, this is something where we've thought about how, bringing in implementation science. And here in this case, we use COMBI, or the Capability, Opportunity, and Motivation to Behavior Change framework, to really try to understand how or what is the best intervention to move forward, and then also to try to understand where implementation strategies are needed. And so we partnered with Brightline Defense, which is an environmental justice organization that has close ties with the SRO community here in San Francisco, with the San Francisco Department of Public Health, and then Lawrence Berkeley Lab at Berkeley. And we wanted to address SRO concerns around wildfire smoke events. They also were just interested in air quality and how poor indoor air quality impacts health. And so one of the gaps that they were requesting to better understand was trying to understand what air quality looks like in SROs, both during and in the absence of wildfire smoke, because despite feeling it, there was no actual documentation of it. And so this was one way where we as the technical experts could help answer that potential gap. And then also to think about ways to look at strategies while trying to address concerns of residents. So this study put purple air monitors in each of the SRO residence units. And then we also surveyed participants, including sending 2 text message surveys a week to better understand behaviors, and also to understand their perceptions of the indoor air quality, and then any health symptoms that they may be feeling at that moment. And since we had purple air monitoring going on all day, we could correlate those to the actual measurements. And so this is just a breakdown of the study population. We had a high proportion of Black participants, and also those that had some high school many with a high school diploma and some college, and then not surprisingly, fairly low income, with 30% reporting an annual income of 10 to 15,000. And then this is each of the residential units that we had a purple air sensor in, which was 17 different units with good data across 3 different buildings. And here on the left, I put some descriptors of the different buildings. The one thing I will highlight is that building 2 has a sort of forced air conditioning system that forces refrigerant through the building that allows for cooling. And that was something that was different than very different from the other 2 buildings. And so building 2 here is in the middle. But what you can see is that didn't really matter what building you were in. Most of the rooms experienced having bad air quality, with many reporting bad air quality on a high percentage of days. And some of this was driven by individual behaviors, but some of this was related to outdoor air getting in. Unfortunately, we didn't have a wildfire smoke event happen during the time of data collection, or maybe fortunately, so we weren't able to capture how these events changed the indoor air quality. But we did find that the amount of outdoor air getting indoors decreased as you went from more summer months to more winter months, most likely reflecting behavioral change over that time, such as closing windows. And then we also found that the amount of outdoor air getting indoors was pretty high, with more than 50% of outdoor air getting indoors. When you think about most households, we think about that range being more in the 20 to 40%. And we also found that for the building that had a air conditioning system, that during extreme heat days, while the air quality wasn't any different, you actually saw that the rooms were cooler, which is important when thinking about also reducing the impacts from extreme heat days. We also saw that certain behaviors improved the air quality, which is shown here by having a positive sign of improving air quality, and things that made the air quality worse. So opening your windows to like high traffic areas, not surprisingly, made the indoor air quality worse. And so there was different factors here that would definitely contribute to the air quality inside. And so from this work, we saw that air quality was similar across the buildings, but active cooling works, which is what I mentioned just a moment ago. We also saw that closing windows has a large impact on the indoor air quality. So kind of thinking about the behaviors that you have to modify in order to change the local environment. And we also saw that air purifiers also improve the indoor air quality, but were in low use. So even though people had air purifiers, they didn't always use them. So now we're in the process of working with Brightline, thinking through a couple of different interventions. We just applied for a CARB grant to better look at personal air purifiers and strategies to increase engagement with personal air purifiers. And then also looking at weatherization retrofits, but in the larger conversation of decarbonization efforts. And so this is sort of where we are now. And then these are our different partners for that work that we've been working closely with over the last few years. And then with that, I can take any questions.
Thank you, Dr. Thakur, for that outstanding presentation. Very, very informative. If there's any questions, you're more than welcome to unmute and ask or submit the questions through the chat. Great. Okay. Well, while we're waiting, Edwin, did you have a question that you wanted to raise?
Oh, no, fantastic presentation. Some of the methods they used. I was really most impressed with your youth researcher program. Like what a fantastic capacity building idea. And in terms of engagement with the community, the results were fantastic. What do you attribute your success for other people who want to emulate those sorts of programs? too. So what made that work? What's the critical secret sauce?
I will say that we approach that program pretty holistically. And so we work with our local partners to help identify youth that may want to be or interested in such a program. We have a very low barrier to participation. We ask them to write a paragraph of what they think the program would benefit, but we also help them with the application process, knowing that's skill building for them. We also think about ensuring that transportation is provided for each of our interns. And so picking them up from home and bringing them on site, knowing that parents and caregivers don't always have the time to be able to do that. We offer breakfast, lunch, and if we're working late that day, we'll also offer dinner for all of our interns. As the school districts actually provides free school lunch program during the summertime, so we'll take advantage of those opportunities as well. And then we also, one of the things I think is important is that we actually want to take them to different colleges around the area. So half of the courses or half of the curriculum is actually taught at Berkeley, so that they're on a college campus and they can kind of see themselves in that space, which is super important.
That's so great.
And also take them to like different college tours around the areas. And so we do try to make it more than just about like in conducting a research project, but also thinking about their own career development, but also how they can become advocates in their own community. So that aspect, we have them meet a lot of CBOs and also government stakeholders that might be, they're going to listen to our youth researchers more than they're going to listen to me. So it's really useful to then see how much impact they have. And actually this summer, one of our YPART interns is now on the steering committee for one of the transforming community grants that Richmond got, which was really exciting. And then sort of full circle, our YPART intern from the Photo Voice project actually was one of our YPART leads this summer and helped lead our interns through the program.
Thank you. Just fantastic. Fantastic stuff. Thank you.
Really amazing. Absolutely. Dr. Thakur, can you tell me a little bit more about the selection of the various frameworks that you incorporated in the studies, and whether, again, to educate some of the individuals who may be choosing as to what to do in that regard?
Yeah, so for the tree planting project, there aren't a lot of IMS frameworks that can be really translated to sort of a place-based intervention. And so I felt CFR, especially with the version 2, which is a lot easier to understand. And also, the way they've reorganized it is reminiscent of the social ecological model. And here, when thinking about tree planting, and also in adding in sort of the environmental justice lens to the work, it really felt like CFR was the right one because it allowed you to consider outer context in the work that we were doing, and which was really important for when you're thinking about a place-based intervention. And so I've looked across many of the different frameworks to really understand like what ones translate better to place-based interventions as opposed to something that might be more at the individual level. For the wildfire smoke study, we went with COMBI mostly because of the situation. And so for thinking about interventions that can be done in rented spaces. So, SROs, everyone's a renter, right? And then also thinking about affordable housing and thinking about what are interventions that can be really operationalized at a renter level without having to potentially interact with the household building owner, because knowing that could cause friction. And so we felt that COMBI allowed a little bit more consideration of sort of behavioral aspects and also resource availability at the individual level that we may not capture as in much detail if we use CFIR there. You can definitely use COMBI at the individual level of CFIR, and there are definitely models doing that. But that's what guided the framework selection for both of those.
Thank you very much. I think one additional question that may be really relevant to our trainees as well, among those who may be present, is about approaching the community. You have built an incredible network of partners. And do you have any high-level advice about what your approach would be in engaging a new community partner?
Yeah, so through PCORI funding, one of their engagement awards, we actually set out to create new partnerships here in San Francisco with CBOs, and had to do it rapidly, given the timeline of the PCORI grant. And I think learnings from that process is transparency, transparency, and transparency of what you are thinking that the engagement would bring. And then, it's really about the relationship building piece and building trust. And so ensuring that your engagement with them goes beyond just like what the research objectives are. And so, with each one of our partners here in San Francisco, even though the grant is end, we actually still meet as a group. And I found other ways of continuing like sort of the stipends for our partners. And then also ensure that the work is really reflective of things that they want to advance forward. So that's been really helpful. But I think we sat out and were like, this is the funding that we have available. This is what we're hoping to answer here. It's not going to, answer everything, but what we're hoping it can get us to is a future opportunity. And then, talking about a track record of having community partners on grants as well. In the past has also helped. But I think it's really about being present and ensuring that you're working on the relationship and not just viewing the partnership as transactional.
Thank you very much for those wonderful advice and learnings. And thank you for that outstanding presentation. We really, really enjoyed it. And if there are no additional questions, I think our time is up. And once again, thank you, Dr. Thakur.
Thanks, everyone.